crack on and get started. So I think hemostasis is a really important topic in dentistry. And I think if you're going to be performing any surgery on people, it's really important to understand the process of hemostasis and obviously how to stop them bleeding during post-surgery. So let's crack on. And this is an example of why it's really important to fully understand the mechanisms that underlie hemostasis and the medications. So this happened last year, as you can see from the title. Dentist is suspended for a year after his patient died when he pulled out 10 of her teeth and she bled to death. So basically, this happened in October 2019, so it was only, what, 9-10 months ago, not very long. And he had a patient taking warfarin, and for those of you who don't know, that's an anticoagulant or sort of like a blood thinner type thing. And what he did is he had 2 appointments with her and extracting 5 teeth in each appointment. And after the second appointment, she left the clinic, continued to bleed at home, and unfortunately bled to death. So that kind of illustrates what an important topic it is for us to know really well inside and out when we're going to be doing these sort of procedures. So this is just a little overview here. So webinar 1 is today. So we're going to be looking at physiologic blood flow and natural clot prevention, and then the mechanisms for formation of blood clots, fibrinolysis and wound healing, and bleeding disorders. And then webinar 2, we'll look at antithrombotic medications and how we're able to treat these patients. So if you're not familiar with all these terms yet, hopefully you will be by the end of the seminar. Niji, can you see my cursor? Just give me a thumbs up, so I can see. Okay, great, I'll need that. So let's start with what makes our blood clot. So this is kind of in reference to what I would say is a pathological clotting. So that's clotting when you don't want it to happen. So say you're chilling in front of the TV, you're all good. You don't want your blood to start clotting. That'll cause you all sorts of problems. So things that can contribute to a pathological clot, which is a clot when you don't want it to happen, can be illustrated in this, which is something called Virchow's triad. So as you can see, it's a triangle with thrombosis in the middle, and that effectively just means clotting. And you've got these 3 corners, which are the areas which can contribute to increased levels of clotting or increase the likelihood of clotting. So the first one is circulatory stasis, and that just represents when the blood isn't flowing very much, it's sluggish and it's pooling, and that makes it more likely to clot. The next is being in a hypercoagulable state. So that's just any state in which you're more prone to clotting due to the processes which we're going to talk about later in the hemostatic processes. For example, pregnancy puts many women into a hypercoagulable state. So that can increase your chance of clotting pathologically. And the third is endothelial injury. So your endothelial cells are the cells that line the inside of your blood vessels, like the lumen of your blood vessels, and they play a huge impact on clotting and prevention of clots, and injury to those endothelial cells promotes clotting. So this just shows a little diagram of laminar blood flow. So you can see here, this represents a blood vessel, and this is the direction of flow. So it's all flowing nice and parallel and in straight lines in a laminar fashion through the vessel. And that's good, that prevents clotting, and that's how your blood should be flowing. When you get stasis and turbulent flow like this, you're more likely to clot. And that can be, a number of conditions can cause that, such as atrial fibrillation, and they promote clotting. And then this is just a quick diagram of an artery wall, well, layers of an artery wall. So you can see in the right in the center of that lumen, sort of lining the lumen, you have endothelial cells. And then underneath the endothelial cells, you have collagen, which is called your subendothelial collagen, which plays a really big part in hemostasis. And then just on the outside, you have these smooth muscle cells, which can contract or relax in your tunica media. So why doesn't our blood clot all the time? Like I said, when you're watching the TV and stuff, your blood's got everything in it, it needs to clot, but why doesn't it clot all the time? Well, that's because we have a number of mechanisms which can prevent clotting naturally. So first of which is that laminar blood flow in the slides previous. Just having that straight laminar blood flow will help to prevent clotting. The next is action of the endothelial cells. So as I said, the endothelial cells have a huge impact on clotting and the prevention of clots as well. So, and they do this by exhibiting what antiplatelet actions and anticoagulation actions. And if you're not familiar with the difference in those terms, that will hopefully become apparent later in the lecture on hemostasis. So the first natural antiplatelet mechanism we have is where these endothelial cells, so you can see my cursor, these endothelial cells lining the lumen, they'll release 2 substances. The first, prostacyclin, and then nitric oxide. And they'll just inhibit platelet aggregation. So they'll stop those platelets from activating and aggregating together, which in turn will prevent clotting, as platelets help with your clotting. So that's the antiplatelet mechanism. And now we'll move on to the first of two anticoagulation mechanisms that you have naturally. So here we have two substances. We have heparin, or heparin sulfate, which is demonstrated by this pink sort of molecule here, and then antithrombin 3 here. And they bind together to form a heparin sulfate antithrombin 3 complex. And you can see here that extends in from this endothelial cell. So you get that complex together, and that extends into the in from the endothelial cell. And that complex creates a lovely little active site, which can inactivate a number of your clotting factors. So again, if you're not familiar with that, clotting factors are what help you clot, and you'll learn all about them later. And just know that there's mechanisms like the heparin antithrombin 3 complex that inactivate a number of these clotting factors, such as 2, 9, and 10. The next anticoagulation mechanism is where you have thrombomodulin, which extends inwards from the endothelium, and that will bind to something called thrombin, and that will activate something called protein C. So again, these mechanisms are quite in-depth, but protein C is an important molecule, so that it can then go and naturally inhibit two of the factors, factor 5 and factor 8. And interestingly, around 5 to 8% of Caucasians in the Western sort of countries, so I think this was done in the US, have a mutation in protein C, which means that it's less likely to break down, or can't break down and inhibit factor 5, which means you're more prone to clotting. And it's a condition called factor 5 Leiden. So it's quite a common mutation. So just a little summary here of the endothelial physiology. You have antiplatelet actions, where the endothelium releases nitric oxide and prostacyclin, and this will help to inhibit your platelets. Then you have the anticoagulation mechanisms and actions, where the heparin and antithrombin 3 complex will inhibit factors 2, 9, and 10. And then you have the thrombomodulin thrombin complex, which will activate protein C, which then inhibits factors 5 and 8. And that's kind of called the protein C kind of pathway there. So just to summarize, overall, what does this mean? You get natural inhibition of your platelets, natural inhibition of clotting factors, and this will prevent thrombus formation. And like I said, thrombus is kind of the same as clotting, slight difference, but all good. So the takeaway message, I would say from this, the takeaway message is just understanding that your blood doesn't clot naturally, normally when you're healthy in circumstances, because there's a number of mechanisms, such as the laminar blood flow and the healthy endothelial cells releasing a number of antiplatelet and anticoagulant molecules. So that's the first little section, natural blood flow and prevention of clots. So that's your physiological blood flow and whatnot. And now we're going to move on to the good stuff, which is the mechanism of formation of clots and some hemostasis. So I'm not very good with computers, so I couldn't join the two slideshows, it became a whole thing. Can you see the slideshow and everything, everyone?
Yeah.
Okay, great, cheers, Niji. So now we're going to move on to hemostasis, which is the main part. So we've talked about why you don't form clots just all the time and naturally, and now we're going to talk about how you do form clots when you need to. So that's hemostasis. So what is hemostasis? So hemostasis is simply the stopping of your blood flowing. So hemo referring to blood, or heme referring to blood, and stasis referring to stopping. So it's the stopping of blood flow. And why does it occur? So hemostasis occurs to stop excessive bleeding when there's injury to a vessel. So when you cut yourself and you rupture a number of vessels or lacerate some vessels, to prevent excessive bleeding, you have hemostatic mechanisms. Without hemostasis, you just continue to bleed, and that obviously isn't good. So we've talked about what hemostasis is and why it occurs. Now we're going to move on to how it occurs. And it's a really complex process, but it's very important, I'd say. It's really clinically relevant because it's where all our anticoagulant, antiplatelet drugs act. So there's three main mechanisms of hemostasis, and throughout the rest of this slideshow, there's going to be kind of like a rule of three things going on. So as in like, a lot of these processes have three mechanisms or three stages, and it just helps remember them if you remember there's three to kind of most of the processes. So the three main mechanisms of hemostasis are vasoconstriction, platelet plug formation, and then the stable fibrin clot formation. And we'll go now. So vasoconstriction. This is the most rapid response to an acute injury. So as soon as you've lacerated or ruptured that vessel, the local blood vessels are going to constrict and reduce the amount of blood flow to that area, which will obviously reduce the amount of blood loss. So and obviously there's three main mechanisms of vasoconstriction. So following that rule of threes I was knocking on about. So here's the three mechanisms. You've got endothelium is a substance which is released by damaged endothelial cells. So when those cells lining the vessel are damaged, they release this substance, and it causes the muscle cells, the vascular smooth muscle cells, to contract, thus causing vasoconstriction. The second is something called the myogenic mechanism, and that's really simple. It sounds pretty cool, but it's really simple. It's basically when that smooth muscle around the vessel is injured itself, it just contracts. The third is nociceptors pathway. So that's where nociceptors, which are pain receptors, and I think that's an MCQ for Manchester's year 2. Nociceptors are pain receptors. There you go. They're activated in the local area when you've got that pain reflex, and they cause muscle contraction. So we've done our vasoconstriction now, and I think the most important thing to know about vasoconstriction is just that it's the most immediate response. It just happens pretty much instantaneously. And the next thing that happens, and it also happens very quickly, is the formation of something called a platelet plug. And that's essentially a grouping or aggregation of platelets here, seen in kind of like the purple. These demonstrate the platelets. So these aggregate and clump together, and they'll block this area of breached vessel to prevent any excess blood flowing out. So these platelets join together, form a huge kind of clump or plug, and they go in to plug the vessel to stop excessive bleeding. Let's get into the mechanism now. This is where it really gets relevant for our drugs. So how does a platelet plug form? And no shock that there's 3 stages following the rule of 3s. So there's 3 stages in the formation of a platelet plug. The first is platelet adherence, and that's just when you get that ruptured vessel, and the platelets rush to that site, and they're attracted to that site, and they bind to the area. And we'll go into that in a bit more detail. The next is platelet activation, and that's where platelets become activated into more active form and recruit more platelets into the area. And then you get platelet aggregation. That's when all those platelets in the area join together to form that platelet plug. So we'll talk about all of these in a bit more detail. So the first one's platelet adherence. And like I said, that's where platelets come into the area and adhere. And they do this. So if you can see this diagram here, you can see the blue endothelial cells. And there's a rupture here, there's a vascular breach. And this is the platelet, this kind of semicircle type thing you can see here with all these receptors sticking off it. And like I said earlier, under the endothelial cells, you have subendothelial collagen. Sub obviously meaning below, which makes sense. You get subendothelial collagen. So it's just collagen below the endothelium. And what happens is platelets love 2 things. They love subendothelial collagen, and they love another substance or glycoprotein called von Willebrand's factor. So when this subendothelial collagen becomes exposed due to a vascular breach, the platelets are going to want to come towards it and bind to it. And they bind to that subendothelial collagen, as you can see here, these little strands, via a GP6 receptor. So they come in and bind directly to the collagen via a GP6 receptor. And the other thing platelets love, as I said, is von Willebrand's factor, and they really love this. They love it even more. It's their thing. So von Willebrand's factor comes in, and it binds directly to the collagen. So von Willebrand's factor is this kind of skin-colored pinky thing here, and that binds to the collagen itself. And then that creates a bridge for the platelets to come in and bind to the von Willebrand's factor via something called a GP1B receptor. You can see here. And you can have some conditions that cause issues with the GP1B receptor, and then obviously just tie it back to a bit of pathology. So platelet adherence, basically platelets come to the area and bind to the collagen either directly via a GP1B receptor or indirectly binded to von Willebrand's factor with the GP1B receptor. So platelet activation is the next stage. So once those platelets bind via their GP1B or GP6 receptors, they become activated. And this causes them to release a number of substances in granules. So the first substance is ADP, adenosine diphosphate. The second substance is thromboxane A2, and the third is serotonin. So the platelets have come in and adhered, they become activated, and they've released these substances. And of particular importance is ADP and thromboxane A2, because they're where 2 of our major drug targets for antiplatelets are, and I'll talk about that in the next slide. Also, when platelets become activated, you can see these non-activated ones here, kind of this rounded, uniform sort of shape. When they become activated, they grow all these kind of extensions and get a bit funky and start attaching to one another, which just increases the surface area and allows them to aggregate together, clump together. That's there. So thromboxane A2 and ADP, like I said, they're really important and they warrant their own slide. And that's because their action is they get released by the activated platelets, the initial activated platelets that have adhered, and then they go out and they get other platelets and activate them. And those platelets become activated. They go and release more thromboxane A2 and ADP, and that release goes and activates more platelets, and so on. So you get kind of like this exponential growth of platelets coming to the area because they're activated by thromboxane A2 and ADP. And like I said, they're really important because major drug targets for antiplatelets. So thromboxane A2 is inhibited by aspirin. So, you know, aspirin is the most commonly prescribed antithrombotic drug, and that's because it inhibits thromboxane A2, and therefore inhibits platelet action a bit. The most frequently used set of antiplatelet drugs is the P2Y12 receptor, which is a fancy name for stuff like clopidogrel is one of them, and that goes and inhibits ADP binding. So it's kind of like an inhibitor of the ADP receptor. So they're really relevant and important for us. And I'll go into those in more detail probably in the next seminar. You've had your platelet adherence, where they come into the site and bounce the subendothelial collagen with or without one WILLEBRAND factor. You've had the platelet activation, where they release thromboxane A2, ADP, and serotonin and change their shape. And now you get aggregations. They've all come together and they need to attach to one another to form a nice firm platelet plug. And they do this via something called a GP2B3A receptor. The names are pretty long and a bit annoying, but what it is. And that's this grey kind of rectangle here. So they express this receptor, and then in between, they bind to something called fibrinogen. So you have a GP2B3A receptor on this platelet, which binds to a fibrinogen molecule here. And then you have a GP2B3A receptor on this platelet, which binds to that fibrinogen molecule. And that allows them to attach. And again, I wouldn't be mentioning if it wasn't clinically relevant. You can have inhibitors of the GP2B3A receptor, such as something called like abciximab, I think. And that's another antiplatelet. So that's where some of the clinical relevance pops in. And then that's your platelet plug formed, basically. So just a quick recap, you have the platelet adherence, where they come into the site and bind to the subendothelial collagen, platelet activation, where they change shape and release thromboxane A2, ADP, and serotonin. And, oh, I forgot to say actually, serotonin just causes more vasoconstriction, so that's all good. And then once you've had these platelets come in and they're activated, they aggregate together by binding to one another with a GP2B3A receptor on each platelet with a sort of fibrinogen bridging network. So that's platelet plug finished. Send that one off, lovely. And now we come to the third mechanism of hemostasis, which is probably the most complicated, but also hugely relevant for our anticoagulant drugs. And that's the formation of the stable fibrin clot. So what is the stable fibrin clot? It's basically, it just consists of sort of a meshwork or network of fibrin which is superimposed onto the platelet plug. So you've got your platelet plug already made there nicely, and then you get this kind of network of fibrin superimposed onto it to reinforce its strength. And that fibrin is interlocked with something called factor 13. Yeah. So why do we need the fibrin clot? Basically, like I said, the platelet plug is actually pretty weak, so it forms really quickly, and it's a great little hemostatic agent that works quickly, but it's easily dislodged because it's weak. And that means that if you have, you dislodge it, then you're going to continue to bleed. So when that meshwork of fibrin comes over and forms the stable fibrin clot, it really strengthens that and forms a much more stable clot, which is much less likely to be dislodged and where you'll have continued bleeding. So we know what it is and why it forms. How does the stable fibrin clot form? And this is the more complicated bit, but we can break it up. So the fibrin clot forms via a cascade of protein activation known as the coagulation cascade. So effectively what happens is you have loads of proteins known as coagulation factors, and they will activate one another in a series of activations to eventually land on something called an activate fibrin, which forms from something called fibrinogen, which is then activated to form fibrin. And then obviously fibrin is your key molecule because that's what you need to make your fibrin clot. So this is the coagulation cascade. If you've seen it before and haven't seen it in a while, you might have just got a bit of anxiety because it's pretty intimidating just to look at straight away, but it can be broken up quite nicely. And you can see here what I was talking about, the fibrin. This is the end result you want. So you want this fibrin forming with factor 13 to form a cross-linked fibrin clot. So with these coagulation factors, you have 1 to 13, but a lot of them are just given names. So for example, 1 is fibrinogen, so it's just called fibrinogen. 2 is thrombin or prothrombin, which is just called prothrombin. Then 3 is tissue factor, and it's just called tissue factor. The others are called factor 12, say here, and they're all done in Roman numerals. Yeah, so let's get into it. So that you can break it up nicely into 3 pathways here. You've got the extrinsic pathway, which is the first pathway to occur, the real initial pathway, and its job is to come in, and you can see here they all converge onto this, and the extrinsic pathway's job is really to come in really quickly and activate a little bit of prothrombin to form thrombin, and that will help kickstart the next pathway, which is the intrinsic pathway. And the intrinsic pathway is like the workhorse. It gets activated kind of by the extrinsic pathway and by a damaged surface up here. And then it goes and produces loads of this factor 10, which will go and produce loads of thrombin. And this down here is the common pathway. And it's called the common pathway because both the extrinsic and intrinsic pathways end and kind of submerge and merge onto this common pathway. And this is the big boy. So this is the one you kind of need to get your head around a bit and learn, because it's really good. Once you know it, and it's really good to learn for your anticoagulant medications. So we'll start with the extrinsic pathway. So here you get the damaged endothelium. So again, the endothelial cells playing a big part, releases tissue factor. So most of the coagulation factors are found circulating in the blood, ready to get activated and form this clot. And like I said, like we talked about earlier, a lot of them are naturally inhibited by the protein C pathway and through the heparin sulfate antithrombin 3 pathway, which we talked about at the start of the lecture. So damaged endothelium releases tissue factor. And this tissue factor is, like I said, is kept in the tissues. It's one of the only coagulation proteins that's not found circulating in the blood, so it's found in the tissues. So when you damage the tissues, you're going to release some of it. It's all going to come bursting out to that area of blood. And that tissue factor will bind to something called factor 7, and it will form a complex of factor 7. So it forms a complex of factor 7, and that will then go and activate factor 10. So as you can see here, tissue factor, where's my cursor there, that binds to activate factor 7, and that will then go and activate factor 10, so 10A. This complex, the factor 10 will then form a complex of factor 5. We'll talk about that later. And that will go and activate some of this thrombin. So you can see this activated factor 10 here. We'll go and activate some of this thrombin here. And then this thrombin, if you can see all the green arrows coming off it, goes and does loads of stuff. All those green arrows represent something that thrombin does. And what it does here that we're going to talk about is it comes back up here where the intrinsic pathway is, and it kind of helps kickstart the intrinsic pathway. So just to summarize, the endothelial cells get damaged. They release tissue factor. Tissue factor will form a complex with factor 7. That will activate factor 10. Factor 10 will activate some thrombin. Thrombin can do loads of stuff, but what it does here is its main job here is to go up into the intrinsic pathway. You could say, like, why doesn't it just go and make some fibrin? It does, but the problem is here is that in the extrinsic pathway, you don't make much factor 10, just make a little bit. You make much more in the intrinsic pathway, so only a little bit of thrombin is going to form. So what it does is it comes and kickstarts the intrinsic pathway to really get it going and get loads of factor 10. So the intrinsic pathway, and there are 2 things that kind of kickstart the intrinsic pathway. Like I said, the thrombin produced from the extrinsic pathway comes and helps us out here, the intrinsic pathway. And damaged surface, or the platelet surface itself from your platelet plug, will activate factor 12. The factor 12 will then activate factor 11. And this is where you just get loads of numbers coming in, but it's not too bad if you learn it. It kind of makes sense. So factor 12 activates factor 11. Factor 11 will then come and activate factor 9, and with the help of thrombin, factor 8 will become activated as well. So factor 12 activates factor 11. Factor 11 comes in along with the thrombin from the extrinsic pathway and helps to activate factor 9 and factor 8. The complex formed by factor 8 and factor 9 will then go and activate loads of factor 10. So not like the small amount of factor 10 we had in the extrinsic pathway. I read somewhere it's about 100 times more factor 10. So you get absolutely loads of factor 10 here. And then that factor 10 goes and feeds into the common pathway. So just to recap up here, you've got your extrinsic pathway, which kicks in here and activates a bit of thrombin, which then feeds in to the intrinsic pathway. Meanwhile, you've got your damaged surface will activate factor 12. That will activate factor 11. Factor 11 activates factor 9, and with thrombin, the helper thrombin, factor 8 is activated. The factor 9 and factor 8 complex will activate factor 10, and this is where the common pathway begins. And as you can see here, the start of the common pathway is activating prothrombin to form thrombin. So just a bit of like housekeeping on the terms. So if anything has a pro before its name, it means it's like a proenzyme. So it's an enzyme which isn't functional yet, and it's waiting to be turned into a functional enzyme. So hence prothrombin is the inactive form, thrombin is the active form. It's the same if you have an O-gen on the end of something. It means it's a zymogen, which is effectively the same thing. It's an enzyme which is waiting to be activated, and you'll see that in a minute with fibrinogen. So we've done the extrinsic pathway, we've got the thrombin to help kickstart our intrinsic pathway. We've done all that, and now we've got loads of factor 10. And that factor 10 will form a complex with factor 5. That complex will convert prothrombin, the proenzyme, into thrombin, the active enzyme. And then, like I said, like we can see on the diagram, thrombin does absolutely loads. It was the one with all those green arrows coming out of it. And the main thing it does here is convert fibrinogen, the zymogen, the pre-enzyme, into fibrin. And obviously that's the fibrin we need. That's the endpoint we wanted to get to our stable fibrin clot. The other molecule we needed for our stable fibrin clot, if you remember, was factor 13. And thrombin's nice enough to also come and activate factor 13 as well. So it does both of those and prepares everything for our stable fibrin clot. There you go. Fibrin forms strands over thrombus to create a meshwork. So you activate your fibrin and thrombin also activates your factor 13. And then that's where you get your meshwork, which is superimposed onto your platelet plug to form a really nice, strong structure. So just a little diagram up here. You can see factor 10 and factor 5 come and activate factor 2, which is thrombin, annoyingly enough. Yeah, thrombin. Thrombin will then come and activate fibrinogen to form fibrin. And also it will come and activate factor 13. And they'll form that cross-linked fibrin clot. So if we go back to our original diagram, above here will be the extrinsic and intrinsic pathway. And then obviously this is the common pathway. So you get factor 5, factor 10 converting prothrombin to form thrombin. And then thrombin converts fibrinogen to fibrin. And also thrombin comes here and converts factor 13 into activated factor 13. And they join together to form that cross-linked fibrin clot. So there we go. Also, from what we talked about in the first lecture, just a little bit extra just to kind of tie everything together, this thrombin comes here and binds to thrombomodulin, which activates protein C. Protein C will then go and inhibit. It has some slight inhibitory sort of actions as well to regulate things. That's pretty cool. So that's the coagulation cascade done. I hope everybody kind of got it. It's quite hard, to be honest. There's just a lot going on. There's loads of stuff. Maybe you could have a look at it afterwards. I'm happy to answer any questions on it, or go through it again at the end if somebody wants or want me to. Because there's a lot going on, but it is really important when it comes to learning about our medications, because all sorts of our anticoagulant medications will inhibit multiple different factors, and you'll be able to understand how them works and how the tests come in for them and whatnot. So done. So that's the tough part over. Platelet plug formation and coagulation cascade is the tough part. Now you just got to repair that clot. So you've made that stable fibrin clot. You've had your platelet. You've had vasoconstriction as your first stage of hemostasis. Then you've had your platelet plug formation. Then you've had your stable fibrin clot. And you've done all the hard work, or your body's done all the hard work. And then eventually you've got to repair it and whatnot. So you've got to repair that vessel wall. And as always, there's 3 mechanisms for this. First is the platelets that fill in that gap between the endothelium, between the vessel wall, will contract or retract, and they'll pull the vessel wall together. A bit like when you're suturing a wound and you kind of approximate the edges to join them together to make it easier to heal. That's exactly what your platelets do. But they're pretty cool, so they don't need sutures to do it. They also release a number of growth factors, platelet-derived growth factor, vascular endothelial growth factor, and they just encourage mitosis of nearby cells, your vascular smooth muscle cells, your endothelial cells, to heal that area. So that's clot repair. And then finally, you've got fibrinolysis. So this is, again, clinically relevant because we have drugs that can impact on this greatly, drugs that we use a lot as dentists, like tranexamic acid. If you understand fibrinolysis, you'll be able to understand tranexamic acid, as well as other things. So fibrinolysis is basically the breakdown of that fibrin clot that you've spent so long trying to make. And it's in the name, really. Fibrin, obviously, referring to the fibrin, the stable fibrin clot, and then lysis, meaning kind of break down, destroy, burst, whatever. So it's the process by which the fibrin here, fibrin polymer, is broken down into fibrin fragments or fibrin degradation products. So again, you've got a zymogen, a proenzyme, much like fibrinogen, but this is plasminogen, and that gets converted to plasmin. Plasmin is the enzyme that goes and breaks down and dissolves your clot. So it dissolves your fibrin to form fibrin fragments. And it does that by getting converted mainly by something called TPA, which is tissue type plasminogen activator. So what will happen is you've got plasminogen circulating, it gets converted by tissue type plasminogen activator into plasmin, and that will break down your fibrin polymer to form your fibrin fragments. So the clinically relevant parts of this, apart from just knowing the process and knowing, like I said, you'll be able to understand a bit about your tranexamic acids and aminocaproic acids. If you don't know what they are, they'll be mentioned in the next lecture. Good. Is that TPA, tissue plasminogen activator, obviously is there to break down the clot effectively by activating plasmin. So it can actually be used as a medication. You can give people TPA. So say they've had an acute, like in a stroke perhaps, and they've got that clot. So they've had a thrombotic stroke. You can quickly give it to them if it's really acute, meaning it's happened really recently. So within about 4 hours normally, you can give them tissue type plasminogen activator in the hope it will help break down that clot and obviously restore blood flow to the ischemic area of the brain. So that's really cool. So you can use it for a number of things. The next sort of clinically relevant part of this is the fibrin degradation products themselves. So obviously, if you have really high, you can measure fibrin degradation products in your blood. So if you have really high levels of fibrin degradation products, it means you've probably had a lot of clotting, because plasmin is working its ass off to try and break down the fibrin into the fibrin fragments. So you're going to create loads of fibrin fragments or fibrin degradation products. And if you've ever heard of a D-dimer test, they're a really common test to test whether people have had clots, then that's what D-dimer is. It's a fibrin degradation product. So high fibrin degradation product is high clotting going on. Yeah. And this just gives us a really nice overview of everything we talked about. So you've got your fibrinogen monomer here. Fibrinogen exists as a monomer. And through the coagulation cascade ending with thrombin, gets converted into this fibrin mesh. These polymers are fibrin. But it's not done yet, because as you can see, this is just a fibrin mesh. It's not the cross-linked one. So then factor 13, which is also activated by thrombin, comes in and cross-links. If you want to do like a bit of spot the difference, you can see that these have got that diagonal line across, these doesn't, and that's the factor 13 coming in and just giving it that extra bit of robustness. It's then broken down by plasmin, which is activated by tissue plasminogen activator, into fibrin degradation products and D-dimer, like I said, which can be tested for. So the takeaway message is hemostasis occurs via the 3 processes: vasoconstriction, platelet plug formation, and stable fibrin clot formation. And I'd really sort of highlight learning your platelet plug formation, your stable fibrin clot formation, because it makes learning about the drugs and the diseases really easy. If you just understand, you can just fit it into what you already know. The platelet plug forms the initial barrier to prevent bleeding, and then the stable fibrin clot is superimposed onto that platelet plug to reinforce its strength. And this is just a quick look at that rule of 3s I was knocking on about earlier. So you've got hemostasis, the 3 processes of hemostasis. So you've got your vasoconstriction, platelet plug formation, and stable fibrin clot formation. Then you've got your 3 processes of vasoconstriction, so your endothelial released, myogenic mechanism, and nociceptors. Then you've got your platelet plug formation, which is where you have adherence, activation, and aggregation of platelets. And then you've got your stable fibrin clot formation. We've got extrinsic, intrinsic, and common pathways, make it the 3 there. So that's a lot done now. It's quite heavy, and I hope you all kind of understood it. If not, then you're more than welcome to ask me in the chat to go back to a bit if I went over it a bit quickly, or there's just something you're a bit unsure about. Hopefully I'll be able to answer it. And just quickly, I just wanted to tie in a little bit of what we've learned, all that bioscience we've learned and physiology, into a couple of bleeding disorders to really tie it all up with a bit of pathology. It's really useful because whenever I see any bleeding disorder, it almost always fits in with this sort of stuff. So you can basically just plug it into what you know and go, oh yeah, if you have a mutation in that, it will do this and whatnot. So it's pretty cool. So the first bleeding disorder is von Willebrand's disease, and the second is going to be a bit about haemophilia, mainly haemophilia A. So what is von Willebrand's disease? So it's usually an autosomal dominant mutation in the von Willebrand's factor gene on your chromosome 12. So you get a mutation in that gene, and it results in a decreased activity of von Willebrand's factor. And from what we talked about in the platelet plug formation, you know, von Willebrand's factor allows adherence of platelets and aggregation of platelets by helping to bind to the GP1B receptor, and then also helping to platelets bind to each other by the GP2B3A receptor. So it has a big antiplatelet effect when you have this disease. But also something else that von Willebrand's factor does, because it does loads of stuff, is it helps stabilize factor 8, from the coagulation factor 8, the coagulation cascade. So without it, you can have lower levels of factor 8. So it can also affect your coagulation. So these defects can be qualitative or quantitative. Quantitative meaning that you have enough von Willebrand's factor, you produce it, but what you produce isn't very good. It doesn't work very well. And quantitative meaning that you just simply don't produce enough. So you've got decent von Willebrand's factor, works all right, but you just don't produce enough. That's the most common of these two. 80% is quantitative. So how common is it? It's said to be the most common inherited bleeding disorder. So it's the most common bleeding disorder, which, yeah, obviously inherited. And it affects around, it's quite hard to approximate because some people are asymptomatic, but it affects around 1% of the US population, an equal male to female ratio. So it's really common. It's way more common than any other inherited bleeding disorder, and you'll see how much more common it is than haemophilia. So around 1%. So what are the clinical features? Severity really varies from mild to obviously extremely severe. We have, but fortunately in von Willebrand's disease, the vast majority of cases are mild, and actually a lot of people go undiagnosed into adulthood until they've had a proper hemostatic challenge. So it happens quite a lot if you're doing an extraction. That's a major hemostatic challenge to the patient, and if they don't stop bleeding very easily, you can and they've had maybe frequent nosebleeds or some of the other features here, you might want to think about referring them to hematology. So like I said, the other sort of clinical signs and features are frequent nosebleeds, otherwise known as epistaxis, gingival bleeding, so sort of unprovoked gingival bleeding and maybe in the absence of inflammation, easy bruising, and GI bleeds are some of the features. So now we'll move on to haemophilia, which is another pretty cool one. So haemophilia basically just means you have a decrease in one of your coagulation factors. One of those 13 factors is not good. But the only ones that are kind of clinically worth learning about are when you have a decrease in factors 8, 9, or 11, because other than that, the others are just like ridiculously rare, anywhere from sort of 1 in 500,000 to 1 in 5 million. So it's, you know, not too much to worry about. So haemophilia A is the most common, and haemophilia A results in a lack of factor 8 activity. So haemophilia A is factor 8, haemophilia B is factor 9 deficiency, and haemophilia C is where you have a decreased activity in factor 11. So A being the most common out of the 3, and C being the most uncommon out of the 3. So it's an X-linked recessive mode of inheritance, meaning that males are mostly affected. And I'm pretty sure it was haemophilia A. I knew it was one of the haemophilias. I'm pretty sure it's A. Actually ran in the royal family for a long time. I think sort of maybe it was the German royal family, or might have been the British, to be fair. And I know that a lot of the young males inherited it and died. So it has a bit of history behind it as well. So how common is haemophilia A? It affects around 1 in 5,000 people. So it's the most common of the haemophilias, but compared to von Willebrand's factor, you know, it's far more uncommon. And as I said earlier, because of its X-linked recessive inheritance, there's a large male predilection. So the severity of haemophilia. So how severe is it? It can be classed into mild, moderate, or severe. And in contrast to von Willebrand's disease, where most of the cases are actually mild, in haemophilia A, most of the cases are severe. So 60% of cases are severe. And when you have severe haemophilia, it's actually classed as having less than 1% of your factor 8 activity, which is, you know, it's a huge decrease, isn't it? I think healthy individuals will have between 50 to 100% of their factor activity. So these guys have less than 1% of their factor activity. So it's extremely severe. And the clinical features of haemophilia A, again, in contrast to the majority of von Willebrand's disease cases that can go undiagnosed into adulthood, severe haemophilia A usually presents before 1 year of age, because it's so severe, you know, you're going to get those signs and symptoms very quickly. And they include excessive bleeding, you've had a cut or some kind of hemostatic challenge, easy bruising, hemarthrosis, which is where you bleed into the joints, and it's very painful, destructive to the joints, and can cause joint immobility. And then you get intracranial bleeds and CNS, central nervous system bleeds, which can obviously be devastating. So I think that, yep, that wraps up bleeding disorders. I just wanted to tie in a little bit of pathology at the end, try and squeeze some in so you can relate it to what we've learned in the bioscience. And that's all of webinar 1. So yeah, great stuff.
Thanks, Reuben. That was really good. You explained everything really well. I know some of those numbers and pathways can get quite intense, can't they?
Yeah, they are. Yeah, a little bit of dedication and you can be all right. But yeah, they are a bit of a pain.
Are you happy to jump into any questions we've got? I know I've got one sent privately.
Yeah. Like I said, I'm like a student, not a haematologist, but I'm happy to do my best to answer any questions I can. So
yeah, nice.
Yeah, if anybody has any, just feel free to ask. Even if you just want me to quickly go back over something, if you missed something for a minute, or you're looking at your phone, I find in half the webinars I spend on my phone and then kind of tuning back in after about 5 minutes. So just let me know.
Yeah. So the first question we got was, is there any difference in bleeding tendencies in patients on antiplatelets and anticoagulants?
Yeah, that's a really good question, Sam. So nice one. Basically, there is a sort of a general difference. So in general, it's, obviously every patient has their own history and everything. But in general, when you're treating a patient who's on antiplatelets, it will obviously antiplatelets stop the formation of that platelet plug, which is that initial fast plug that forms. So they'll tend to bleed longer when they're on antiplatelets. So you can have a prolonged appointment time maybe to see that. So they don't form that initial platelet plug, so they tend to bleed longer. But once you've stopped them bleeding, they don't recur. The bleeding doesn't recur very often because there's nothing wrong with their stable fibrin clot. So that can still come and be superimposed onto that platelet plug. So yeah, once you've stopped them bleeding, you can be relatively confident they're going to stay stopped. Whereas with anticoagulants, the platelet plug's fine. So that initial, that quick rapid response is all right. So it will stop that bleeding very quickly. But then you don't really get that superimposition, or very much superimposition of that stable fibrin clot. So it means they're more likely to recur bleeding at a later date. So a bit like that was maybe what happened. I think that's what happened in that case with the dentist. She'd stopped bleeding in the clinic after her 5 extractions on the 2nd appointment. And then she'd gone home, and because she was on warfarin, which is an anticoagulant, she hadn't been able to form that stable fibrin clot, which means that she will have then continued bleeding at home, and unfortunately, in that case, passed away.
Yeah. Yeah, thanks for that. I don't think we have any other questions, so we'll wrap it up there. But yeah, thanks for spending your time.
No worries, thanks everyone for
answering all those questions as well.
The only other thing I had is, do you have any recommended reading sources or anywhere you got your information from? Anywhere you can recommend any books or anything like that?
Yeah, I did. I got it from quite a lot of it from one book, which is, give me a sec.
And amongst the library.
Yeah, that's it. No, I can't find it because I find it. It's kind of just like it's like 1,000 pages, so I wouldn't recommend reading it all. But it's called Robin's Basic Pathology, or like Kumar and Robin's Basic Pathology. Any kind of physiology or pathology textbook is pretty good. Another thing is there's like a bioscience website called lumens.learning, which sounds a bit funny, but it's really good. And then what also I did is I did a lot of reading, and then there's a really good it doesn't sound great, but there's a really good channel on YouTube from a professor at Stanford, and he covers hemostasis in about 5 hours of content, to be fair, but he covers it really well, and it's great, and all his stuff is evidence-based. So after you've done your reading, to kind of help solidify it in and get an idea of some of the processes, it might be worth just looking it up. It's called Strong Medicine on YouTube. It's pretty cool.
Did you summarize those 5 hours for us then?
Oh yeah, pretty much, yeah.
I think what we can do is, if you can give us all of your resources, we'll write them down, we'll post it on our story so everyone can easily see where you've got it all from.
Yeah, sure, no worries. I'm happy. Yeah, like you say, you can send the slideshow or whatever if you want, or anything like that. So
yeah, that'd be good. Yeah.
No worries.
Yeah, we'll wrap up there. We've got